Now we have the next session, which is Industry Symposium in collaboration with Feroz Sons Laboratories. And this symposium focuses on a very important and emerging epidemic. With diabetes, there comes other complications, and one of them is the fatty liver disease or metabolic dysfunction associated steatotic liver disease. So to focus on that, to start the session, I first invite the chairpersons, and the first chairperson is Dr. Rajinder Reddy, and he is the inaugural founder professor in hepatology at Perelman School of Medicine. He is director of hepatology and director of liver transplantation. He is an internationally known expert in liver diseases, especially in primary biliary cirrhosis, in alcoholic liver disease, and especially the MASLD and MASLD. Thank you, sir. Next, I invite Dr. Abbas Raza. We all are we know about him, but I take the privilege to introduce him. He's a consultant endocrinologist at Chowkathanam Hospital, but he is the current president of International Congress of Endocrinology. He's the past president of South Asian Federation of Endocrine Societies. He's the past president of Pakistan Endocrine Society. He's the founder president of ACE Chapter Pakistan. So thank you, sir, for joining. And next, I again request Professor A.H. Amir, if he's in here. He is the head department of diabetes, endocrine and metabolic diseases, Hayathabad Medical Complex. He is the past president of Pakistan Endocrine Society, and he is the past vice president of South Asian Federation of Endocrine Societies. Thank you, sir. For the talk on the today's topic, MASLD, NAFLD, and it's all about the metabolic health, Dr. Bilal Hameed. He is the professor of medicine and ambulatory director of hepatology at University of California, San Francisco. He has been the program director for transplant hepatology fellowship, and his research includes NASH, primary sclerosing cholangitis, and other liver diseases. Thank you.
Assalamu alaikum, everyone. Thank you so much for the kind introduction. I think the main purpose is for me to learn from all of you what the diabetes and endocrine societies have done. I think the liver is far behind. Always, in hepatology, we worry about when patient already started having complications from liver disease and how we can work together to prevent when these complications happen. So these are my disclosure. I have done a lot of clinical trial in metabolic associated liver disease and different companies. So when we look at the progressive nature of this disease, the MASLD, and I'll talk about the new nomenclature, is one of the most common liver disease in the world now. And we'll understand, and the audience here understand with the diabetes, obesity epidemic, what are we doing? But the liver goes from different phases. The first thing what we see in patients is simple steatosis that happen in about 30% of the population in the world. And this data is increasing like up to 35%. And out of those 30%, about 12 to 40% will develop more severe form of injury, which we call steatohepatitis, when the liver steatosis started causing inflammation, ballooning. And those are the patients who are at risk of fibrosis. And ultimately, 1/3 of those patients will develop cirrhosis. And once you develop cirrhosis, they are at risk of developing complications, needing liver transplantation, hepatocellular cancer. So just to put some numbers in perspective, if you calculate the Pakistan prevalence, about 25 to 30%, estimated about 35 to 70 million people with some steatosis present. About 4.5 to 2.5 million people already have steatohepatitis with fibrosis, and about 1 to 6 million people with cirrhosis. Now we're already seeing that we are having difficulty tackling hepatitis C. As most of you know, Pakistan has now the highest prevalence of hepatitis C. Now, many of these patients not only have hepatitis C, also have metabolic syndrome, and they may have combination of both hepatitis C and fatty liver disease, and that is also very concerning how we will address this. Now, about same thing, about 500,000 people are at risk of developing hepatocellular cancer. But when we look at, initially we were talking about fatty liver disease and steroid, but in the end, it's a metabolic disease that is starting, the diet-induced obesity, and the metabolic stress, the systemic inflammation and fibrosis is happening the same pathway in all the organs. And same thing happened with the liver, that patients start having inflammation, ultimately develop fibrosis. But the similar mechanism is happening in the arteries, in the heart, pancreas, and also in the kidneys. Now, when we look at the individual data, that patient with fatty liver or metabolic associated are increased risk of developing all these complications. So until we address, and that's where I'm so happy the discussion about the prevention is coming in. And countries like Pakistan cannot afford this thing so we need to work on the prevention of this and go into the grassroots level. And we are failing in America also badly, because if you look at our obesity epidemic, it's increasing significantly. Now, it's a multi-system disease, and patient with MASLD has all these complications as together. Now, when we look at the comorbid conditions that happen with MASLD patients versus inflammation of patients, it's clearly associated with worsening metabolic syndrome. So this is one of the articles that we work with JAMA to look at. So when we look at the general US population, it's about 40% obesity, but as soon as the patient has steatosis, up to 50%, and patient with MASH is about 80%. Same with hypertension, type 2 diabetes, and dyslipidemia. So the more risk factors you have, more chance of developing this severe form of fatty liver disease or steatohepatitis. So that's why it becomes more important to focus on these risk factors. Now, the one thing I think many of you may already aware of it, that last year the nomenclature was changed, and for many years, for decades, in 1980s, the term non-alcoholic fatty liver disease was coined because we didn't know how these patients were getting it. These patients were not drinking alcohol, but over the last couple of decades, we understand the metabolic dysfunction as the major factor. So the new terminology from non-alcoholic has changed to metabolic associated steatotic liver disease, and then metabolic associated steatohepatitis. It's a mouthful, but just MASLD or MASH. Now, the main difference that happened now with the new nomenclature is that you only need one metabolic risk factor and steatosis to label anyone to have MASLD. It's become more diagnosis of inclusion. In the past, we have to exclude all the causes of liver conditions. And the other important thing, it was very stigmatizing. When we used to call patient non-alcoholic, they still, family members thought that alcohol was a cause of it. And the word fat in it is also very stigmatizing. So in Asia, before the change in this nomenclature, it still uses the word MASLD, which is metabolic associated fatty liver disease. But the MASLD was Europe and America and LA, and now it's been implemented, and more than 80 societies have endorsed this new nomenclature. Now, the one thing in the new nomenclature which we were missing is there were a lot of patients that we were seeing who were drinking moderate amount of alcohol. They were not labeled as alcoholic liver disease and also have metabolic syndrome. And the new entity that was formed, or which we have in the nomenclature, is called MetALD. These are the patients who have metabolic syndrome as well as moderate amount of alcohol. We were excluding many of these patients from our prospective cohort study, and this is a new area of research that has developed. The early data has already shown that these patients with MetALD has increased risk of progression to liver disease and complications from liver disease. Now, this is a simple way of understanding, and again, as I mentioned, you only need one of these cardiometabolic risk factors with steatosis, and this is available on our AASLD website if someone is interested. So let's talk about the regional and global prevalence. Zubair Younisi is one of the best epidemiological data has produced over. So what we think about that the pool prevalence of MASLD is about 30% right now. So worldwide estimated about 1 billion people, and the MASH, which is the fatty liver causing inflammation and fibrosis, up to about 250 million. And out of these people, 22 million has advanced fibrosis or risk of developing cirrhosis. And you look at the whole population, whether it's North America, one of the highest prevalence is in Latin America. There are definitely some genetic factors also associated. We are trying to understand PNPLA genes is associated, and the Middle Eastern region is also very high. But Pakistan and India, we are not that far behind, which we all understand that we already seen the obesity and diabetes epidemic here. So this is some of the data, and we need definitely more studies in Pakistan. This is one of the studies early on in 2020 that suggests 15% of general population, but PKLI has the data that 30% of patients or people coming for living kidney transplant donation has fatty liver disease, and then the latest one from the Lancet gastroenterology paper shows about 25. So it's anywhere between 25 to 30% of population, but this is increasing significantly. And this was a very interesting paper from Maru, Dr. Ranella in Northwestern. They looked at the obesity prevalence and the calorie consumption and the rate of fatty liver disease. So if you look at the areas where you have more calorie consumption, the increase in the fatty liver was clearly associated. Now the diabetes, most of you are aware, you all see patients in it, and this is some of the studies that the global prevalence of MASLD in diabetes up to 55 to 70%, and the steatohepatitis up to 30 to 40%. And the prevalence of fibrosis, which we call F2 or F4, is up to 12 to 20% of the diabetic population. And this number is increasing, and so there is a whole focus of understanding these patients who have advanced fibrosis and how we identify early before they reach. And there are certain pathways which I'm gonna discuss next. But before we talked about, many of you are aware about, when we understand there are many pathophysiological aspects that happening in the liver, and Dr. Schwartz was showing about this liver mechanism, but beside insulin resistance and lipotoxicity and gut dysbiosis, what we have seen in patients with MASLD, it's not only the liver and cardiovascular, the increased risk of extrahepatic malignancies. There's increased risk of breast cancer, increased risk of kidney cancer. So there's a lot of pathophysiological mechanisms that has been going on. And diabetes and fatty liver share the same pathophysiological mechanism. Now also there is some older data that MASLD and type 2 diabetes increased risk of vascular complications. So to take the patient, this paper which is used the old terminology of NAFLD, if you take patient with or without NAFLD, all these complications, whether it's coronary vascular disease, CVA, peripheral vascular disease, whether it's micro or macro, are increased in the population with diabetes. Now, there are many studies have shown that MASLD increases independently cardiovascular disease and new onset heart failure, atrial fibrillation. This is the study which they looked at about 36 longitudinal cohort study, up to 5.8 million individuals with a follow about 6.5 years. And you look at all the cardiovascular and non-fatal complication, which much higher in MASLD. And if you have more fibrosis, the risk of having complications is much higher. And same with diastolic heart failure was also increased significantly in MASLD. So these are also considered an independent risk factor for cardiovascular disease and heart failure. Now, we all talk about fibrosis, and people who doesn't have an idea in the medical school, when we talk about fibrosis, either on non-invasive or liver biopsy, the liver goes through different phases. We call stage 0 when you have no fibrosis of the liver, then stage 1, stage 2, stage 3, and 4 is what we call cirrhosis of the liver. So anyone which has stage 2 or higher, we call advanced liver fibrosis. Now, there are many studies have done that it shows that your overall mortality increases with your fibrosis stage. So as soon as you hit F3 and F4 fibrosis, also your cardiovascular mortality started increasing with the stage of fibrosis. It's not surprising that once you have more fibrosis, your liver mortality, your risk of developing cirrhosis, portal hypertension complication, liver cancer will increase. So fibrosis stage is the single most important determinant in MASLD patients, and therefore the whole focus is identifying patients who will be at risk of this fibrosis. And also, there is data that diabetes is the strongest predictor of this advanced fibrosis in MASLD. Enhanced data, and there is a data from German tertiary care, that if you look at all the risk factors, diabetes keep coming in as a very important risk factor. So therefore, population of patients with diabetes and MASLD is a much higher rate. Now, this was an interesting paper. It was in 2018 when they asked most of the endocrine and primary care, mostly endocrinologists, and asked them, what do you think, what proportion of your patients you see in the clinic will have advanced liver fibrosis or cirrhosis? And majority is about like 1 to 5%, some says less than 1%, and the actual prevalence is much higher. So I think as a community, we need to also understand that patients with diabetes has a much higher risk of fibrosis. And this education is increasing, and meetings like this that we learn from all of you, and we have to discuss how to care for these patients, because when we develop these models integrated, we don't have enough GI and hepatologists in America and Pakistan to care. So it has to be through primary care and endocrinologists and understand and prevent these diseases. So there are many guidelines out there. So it's not surprising whether the latest EASL, and the amazing thing that European Society of Liver Disease, the guidance document was made in combination with European Association Study of Diabetes and Study of Obesity. So they all three combined together to come up with a guideline. American Diabetes, ADA, ASLD, and American Clinical Endocrinology has came. All these guidelines have suggested that all the diabetic patients need to be screened for advanced fibrosis. So in the clinic patient, when you are seeing these patients, you need to identify, it doesn't matter, you don't need to know whether they have fatty liver disease. That's already shown more than 2/3 will have fatty. You need to screen whether they have fibrosis or not, and how would you do it? So what are the clinical assessment tools that are available right now? So when we talk about the referral pathway, which patients need to be seen, it has to be based on evaluation fibrosis. I hope I shown you the data about what's the importance of fibrosis. It has to be easily accessible as a first-line test. Cannot, in America, we say it can be calculated automatically. Our electronic medical record can calculate it, inexpensive, and have a high negative predicted value. So when we think about this MASLD clinical care pathway, and many societies have it, but I want you to simplify for you. It's a tier 1, which is non-invasive blood test for fibrosis. And if someone has more fibrosis, then the next step will be a liver stiffness measurement. Many of our endocrinologists in the US have an access to a FibroScan, and they're doing it in their clinic to evaluate for fibrosis. But that's the one thing we need to talk about more. So the simplest recommended by guideline is a test called FIB-4. FIB-4 is an easy test, which is ALT, AST, platelet count, and age. Although patients who are more than 60 years or younger, it's not as validated, but this is still have shown. And FIB-4 is also been associated to show the liver outcomes and mortality. So patients with high FIB-4 has been. And so the number you need to remember is 1.3. There's always some caveat, but the number, if it's less than 1.3, you can rule out advanced fibrosis. If it's greater than 1.3, we need to do more testing. And then the second test is this transient elastography. It is an indirect measurement of the fibrosis. And the number that we say the level, if someone has less than 6, it's normal. 6 to 8 is stage 1, 8 to 10 is stage 2. But the number we worry about is 8. If it's more than 8, patients likely have stage 2 fibrosis. Again, there are many caveats and there are other things, but this is from the level of referral pathway that which patient needs to be established. I'll just show you there are many other similar pathways about the EASL, and the latest, which was just published last month, that if you have a patient with type 2 diabetes or obesity with 1 cardiometabolic or someone with elevated, you start with a FIB-4. If your FIB-4 is greater than 2.67, these patients need to be referred to a hepatologist or gastroenterologist. Again, it's all depend upon the axis whether you have it, but this is based on it. But if it's 1.3 or 2.67, this is an intermediate range, and that's where we order a FibroScan. And if someone is less than 1.3, we don't need to do anything, but we need to recommend them about the lifestyle intervention, talk about the weight loss, diabetes management, and reassess the FIB-4 depending on the risk factors every 1 to 3 years. And if it's increasing, then need to be established in that regard. So lastly, we'll talk about what is availability right now, right? And this is just, again, going back that we don't have something like which is right there, except for we did have in March first approval of first FDA medication for which we call resmetirom in America. But the weight loss, like lifestyle, diet, weight loss medication, bariatric, treatment of diet with diabetes with the help of endocrinologists. And as a hepatologist, I am starting a lot of these treatment for obesity and even asking to change because some of our primary care are not comfortable. One thing is statins are completely safe, in fact, beneficial in patients with MASLD. There's a lot of data. I don't have time to talk about all these like data about it. And then there are patients with what we call at-risk NASH patient with inflammation and stage 2 fibrosis. We then talk about liver-specific therapies in a selected group of patients. We have to talk about all the modifiable risk factors. So we talk about all these, if patient is taking any new medication that can impact, talk about alcohol use, high fat, fructose has been associated with it. Now, when we look at the dietary studies, Mediterranean diet, intermittent fasting, all these have shown, but the diabetes literature is full of it. As a diabetic patient comes in, you need to follow a diabetic diet, but the access to nutritionists is even hard, even in America. So how do we make it easier to get access to these things? Now, weight loss has been shown in many different studies have been associated with improvement. And what we tell them is about 7 to 10%, but patients who have 10% reduction or loss of weight, they have resolution of inflammation in 90%, fibrosis regression in 80%, and steatosis improvement in 100%. This was an amazing 52-week lifestyle intervention study. They were following it, providing everything. But guess what? Like in other studies, only 10% of patients were able to achieve the 10% weight loss mark. So it was despite everything. Although this field has changed with the GLP-1, with obesity, this has been changed significantly, but that's what we recommend when we look at it. Now, also, we talked about there are a lot of different background therapies that you all much more aware of it and knowledgeable and using these medications. But again, going back to the same, there are all these medications and how we are working in an integrated model at UCSF. We are working on having metabolic precision where the patient can see an endocrinologist, hepatologist, get a fibroscan, preventive cardiology, but we not have very selected patients. But there are data about GLP-1, statin, fibrate, SGLT2. So there are all these. And with newer and newer therapy, polypharmacy becoming common. So we need to work together that which patients can be on which medication, identify these high-risk group. Now, this is from the American Endocrine Society, where they talk about diabetes management MASLD. I'm not gonna, but there is more and more focus. There is studies with Dr. Ken Kusi about pioglitazone has shown any liver benefit, but GLP-1 is keep coming again and again. And I'll just briefly show about some of the targeting pathophysiological processes we are working on. We are working on insulin resistant and lipid metabolism, target related to lipotoxicity, inflammation, and the holy grail is always if you can reverse the fibrosis. Now, there has been a phase 2 clinical trial published in New England Medical Journal of semaglutide in patients with MASH. It was a 72-week study of 320 patients with fibrosis stage of 1 and 3. Now, most of these studies, they have different clinical outpoint of histology, where they wanted to show whether you have resolution of NASH with no worsening of liver fibrosis or improvement. If you look at the outcome, they will have improvement in inflammation, but there was no significant difference in fibrosis. We just finished a phase 3 clinical trial, and the data likely come early next year, and it may be approved beside diabetes and obesity as the second medication for MASLD independently, but we'll have to wait for the final. FDA has a very strict protocol. And lastly, this is the first FDA-approved medication, which is the THR beta agonist. The THR beta is in the liver, and we thought that liver is subclinical hypothyroidism. It decreases the R3 inactive and increase the R3, and clinical trials have shown lower liver fat, resolve MASH, and lower LDL. And based on this, data, that FDA gave him a provisional approval. But if you look at the comparison of NASH resolution, it was 30% in 100 milligram arm and 10% in placebo, so 20% different. not that huge, $45,000, $50,000 medication for 1 year. So it's pretty expensive, but a lot of people are using. And then the fibrosis improvement is 26 to 14%. But this is the first step, and we need to see whether likely the future will be combination. There's already combination trial with like multiple different medications. In the end, MASLD is a part of multi-system disease, and we need a multidisciplinary approach. In the US, we talk about the primary care endocrine. Mainly the primary care will be the backbone of it, because we can see, unfortunately, Pakistan does not have that robust primary care system. So who will be? A lot of hepatologists have to become the primary care doctor. But in the end, in any disease, the patient has to be in the middle, and we have to think about holistically. We need to tailor everything culturally, appropriate patient education, and what is Pakistan needed. We cannot just based on what US and what we are recommending. We know what our population is, how we can educate. And the point was like, we need to start from the schools, because that is where the money is. So what will it take to control the metabolic? It's a multi-pronged approach. We have to systemic investment to increase the awareness for metabolic syndrome, the diabetes, metabolic disease, improve surveillance, and development of care pathways. Without increasing the patient or provider burden, it has to be cost effective and enhance outcome with access to care, better prevention, and early detection. But the local and global partnership, hopefully the IDF, and we can, even ASLD level, we can work and about this together. I think that would be an amazing platform. Thank you, everyone. And this is, I stole from my mentor, Arun Sanyal. It's a Chinese saying, superior doctors prevent the disease, mediocre doctors treat the disease before evident, inferior doctors treat the full-blown disease. So hopefully we can be superior doctors. Thank you, everyone.
Thank you, Professor Bilal, for such an elaborated talk. Now I request our worthy chairpersons to give their valuable comments.
All right, thanks very much. As a background, I'm a hepatologist and a transplant hepatologist. So I see people at the top of the pyramid, that is people who have advanced liver disease, coming with liver failure, requiring liver transplantation. But one has to look at it as a global problem. It's a huge problem, and you should really look at the people at the bottom of the pyramid. So Bilal nicely highlighted the liver disease component of metabolic syndrome associated steatotic liver disease. But it's, we need to stay away from having a tunnel vision. Hepatologists looking through one tunnel, endocrinologists looking through one tunnel, the cardiologist looking through another tunnel, and then there's nephrologists, and then increase in colon polyps, colon cancer, all kinds of cancer. So we really need to have a global perspective. One thing I hope Bilal has impressed upon you is when I see a patient with fatty liver disease, I give a lot of attention to diabetes, presence or absence of diabetes. If you look at any number of studies, the patient who's likely to have progressive liver disease often has diabetes. So this is the perfect forum, perfect audience to kind of at least tie them together, assess them for liver disease, intervene, etc. So, but that's the way I see it. But I think, as you pointed out, we need education. It's a huge public health problem, and we need education of the population. So we say diet and exercise, and I was in India, and I said, well, exercise 20 minutes a day. And one person in the audience got up and said, but where are the parks? We don't have any parks here to go and exercise. So we need to retrain ourselves in how we tell people to get some exercise, So be it through TV or other mechanisms, we need a huge education effort. And it's sort of been interesting. Earlier on, I heard esteemed gentleman talk about non-communicable disease, and that's maybe what the problem is. It's a non-communicable disease, and so it's not on the radar of governments and agencies. But that's what we need. So with that, I'll stop. Thank you.
Excellent talk. And like I've heard you before, like always. I have a quick comment. You were so comprehensive, I don't think there's much to add at this point. The comment I have is that we talk about fatty liver disease and the progression of fatty liver disease from F0 to F4, cirrhosis, hepatocellular. And we talk about treatments like GLP-1s and the upcoming treatment options that we have. Please comment on something I'm going to say and agree or disagree with me that if you really want to make an impact on the fatty liver disease and the end products of this fatty liver disease as cirrhosis and fibrosis, you probably have to intervene not at the stage that we are usually intervening, which is F2, F1, F2, F3 stages, and we want to treat them and then get an impact in the next 20 years. Probably we have to screen them at F0, F1 to have an impact on those diseases in the next 20 years. Number one, would you agree with the fact what I'm saying? And number two, somehow we never address F0, F1 at this stage. We usually address them when we talk about treatment in F2, F3. So do you think we need, as a globally, we talked about diabetes prevention, working with children in diabetes and making an impact, but we don't talk that much on preventing the fatty liver disease and acting at the earliest stage to prevent the end product. Although the cost would go up higher, but there are some cost-effective treatments as well.
Yeah, I think excellent point. As a hepatologist, we want everyone to screen, but if you talk to the epidemiologic in screening, they like shout at you. And even this, for this selected group. So there are 4 group of patients right now. The screening in general population, there's a risk of fibrosis about 0.9% or even 0.5%. So the 4 group of population, the recommended screening for is type 2 diabetes, obesity, patient with alcohol use, and patient with first degree relative of MASH. Things will gonna change in the future, but I think that's where, but it doesn't take away the fact that patients with the lifestyle, and I think that's where the point you're trying to make. So I think what we will gonna do differently in that is still the same recommendation with lifestyle, right? And so these guidelines have to change because based on what are the patients which are the highest risk. Now, one thing is that for the risk of fibrosis progression from one stage to another, it's normally takes 7 to 8 years, right? And there are 10 to 20% of patients, they are fast progressors, right? And those are the patients with type 2 diabetes are the biggest one, patient with alcohol, age, postmenopausal, the risk increases. So I think that right now, I think the guidance still, but I would not be surprised that we would be, but I think the population will be like the whole world. We have to screen and then get the FIF4 and other testing, but it will be available. But your point is well taken. I think the guidelines will, but right now it just the focus is in that group, right? Because they are the cardiovascular, all these mortality, the F2. So that's where we are right now.
Thank you very much. Excellent talk. And just one simple question. Elastography, how often where you practice endocrine do the elastography, and is it operator dependent? Because we struggle to get that done very, very often.
Yeah,
and then
so
I'll just have a
yeah, so I think at different places where do have it, most of the time it's for the research. Everyone has a research fibroscan, and but it's like cost in America is $150,000 to $200,000, and the EchoSense. But there are newer companies are out there, and things are gonna change very quickly with what we call NIT, non-invasive testing, and so that would be. But fortunately in Pakistan, maybe not endocrine, many people have more access, and now we have portable fibroscan. So if you, and I think that's where the investment is, not like the big machine. So people are, we have these mobile vans where we can go to the public and do the fibroscan. So the cost, all of these will kind of come in, but our place luckily be able to buy a few and then have the endocrine, because that's where the patient not going to come to us. We have to identify those patients. And when we do, I think if you get clinical trials, it's easy to get all these machines and get it done.
Yeah, thank you very much. Last but not least, I think I would like to congratulate the conference organizers, particularly Scientific Chair Ali, because he has given us provision and opportunity to discuss with the cardiologists, with hepatologists, with so many people around. And I think one person who's missing here is probably respiratory physician. Maybe you can try it next time. So this is a multidisciplinary disease. As a metabolic physician, we like that, to interact with people, and it is lovely to see all these specialties sitting together and talking about one thing, which is a living human being and a health of a human being. And I think your Chinese proverb said it all. Thank you very much.
Thank you so much. Now I request the worthy chairpersons to please distribute the shield of appreciation to Dr. Bilal Hameed.
I came from Gujranwala yesterday and I attended the full session and I went back to my city at 1 a.m. and then came back at 8 a.m. I attend 2-day sessions and 70 to 80% of the lecture delivered by national and international speakers are related one another way to diabetes mellitus. And every lecture I think is a state-of-the-art lecture and it adds my knowledge. But one thing is missing. What is that? Insulin was discovered in 1921. Since that time now is 2024. 5 Nobel Prizes have been given to different lucky people who work on diabetes or insulin. My question is that please give me any advice, suggestion, or any guideline that I work on that or my colleagues work on that, and maybe I or maybe some other one that can get the 6th Nobel Prize on diabetes mellitus.
I think I'm definitely not getting that Nobel Prize, so I will let the endocrinologist answer that.
I probably cannot give the most scientific way of putting this together, but I think in this time and age, probably if insulin was rediscovered, it wouldn't be getting the 6 Nobel, 5 Nobel Prize that it got. Probably something else will get the 5 Nobel Prize, because we have known now just treating the symptoms. And again, I'm sorry if I'm not answering the question in the most appropriate way, but now we know that, as rightly put together by the speaker as well as other people in the room, now the treating the disease is not the main focus of medical science now. Treating the cause of the disease is more focused. So the disease modifying, so now I think more awards and more things are being done in disease modifying problems rather than treatment arm of it, which still treatment era was almost at the verge of finishing. Disease modifying era is starting, and I think we are seeing a lot of new medication, new treatment options which are actually modifying the disease.
Thank you so much. Now I request the chairperson to please distribute the shield to Dr. Bilal. Thank you everyone, and it was a long session. Now tea is waiting for all of you. Enjoy your tea please. Thank you so much.